عليكم السلام. أهلا دكتور.
صوتي واضح عيني؟
نعم دكتور واضح.
سلايدات واضحة؟
واضحة.
اوكي. بسم الله الرحمن الرحيم. Our lecture today is basal ganglia disorder, movement disorders. But please don't understand that each movement disorder is related to the basal ganglia. Movement disorder is the hallmark of the basal ganglia disorder, but not all movement disorders are related to the basal ganglia. Movement disorders is a group of neurological syndromes characterized by abnormality of the form and or velocity of movements of the body. According to the American Academy of Neurology, which is the paramount institution of neurology in the world, movement disorders includes hyperkinetic movement disorders, akinetic rigid movement disorders, ataxia, which have three types of ataxia, gait disturbance for any cause. So only first two is related to the basal ganglia. The major part of movement disorder is basal ganglia disorder. Movement disorder can result from biochemical and or structural abnormality in the deep structure, deep subcortical gray matter structures termed basal ganglia. There is a important group of movement disorder called drug-induced. In drug-induced, the abnormality is biochemical, and there is no structural abnormality to cause movement disorder. In the basal ganglia, the basal ganglia control muscular movement by influencing the cerebral cortex. Basal ganglia is a group of ganglions, but caudate nucleus and putamen, which is called neostriatum, form the main site of receiving input. Globus pallidus form the major site of the output, leave the basal ganglia. The output of the basal ganglia project by the way of the thalamus to the cerebral cortex. Cerebral cortex don't receive anything directly except from cortex. And from cortex to cortex, yes, but from any organ other than olfactory nerve should be should reach the thalamus, and the thalamus project fibers to the cortex. Basal ganglia pass in this pathway, usual pathway. The basal ganglia regulate primary initiation of movement. Extrapyramidal, which include basal ganglia and cerebellum, don't affect the motor unit directly. It affects the motor cortex. Cerebellum adjusts the termination of the movement, and basal ganglia regulate primarily the initiation of the movements. Disorder of the basal ganglia are of two types. Akinetic rigid disorder, we have only one example. I think Dr. Abdul Karim in next lecture will give you an idea about that. and hyperkinetic disorders, which is the scope of this lecture. Hyperkinetic disorders are characterized by involuntary movements. Involuntary movement is excessive degree of involuntary motor activity. Include tremor, chorea, melismus, dystonia, ethytosis, and tics. Parkinson's disease include both types of motor disturbance. As a disease, Parkinson have tremor and rigidity, poverty of movement, and excessive movement, both in the same patient. Clinically, any patient presented with movement disorder, we should evaluate we should evaluate it by answering questions about this item. The age, because the types, distribution, and the etiology of the movement disorder is classified according to the age in most of the time. Temporal profile. Each movement disorder, especially dystonia, is classified according to the temporal profile. Which body part or parts affected? This point may be related to the first 2 points in some movement disorder. What is the exacerbating factor and relieving factor? Exacerbating factor may include task-specific, which is characteristic for some movement disorder. What is the associated neurological, psychiatric, and systemic feature and cognitive impairment? Movement disorder is not a disease, it is a manifestation. So it could be part of a disease or at least a syndromic diagnosis. A paramount group of movement disorder is a drug induced. So we should ask about drug exposure. Many movement disorder is familial. So we should ask about family history. Past medical history sometimes is very important because many movement disorder related to systemic disease like chorea. Okay. As the Americans said, let's cut to the chase. I will take the movement disorder one by one and start with the most common one, the tremor. A tremor is a repetitive, rhythmic, oscillatory movement of one or more body parts. Tremor can affect the head, can affect the lower limb, but mostly in the upper limb. Tremor is enhanced by emotional stress and disappear during sleep. Classification of a tremor is according to its relationship to voluntary movement activity, according whether it occurs at rest, during maintenance of a particular posture, during movement. So it's divided into resting tremor, which is characteristically revealed in Parkinson's disease, and action tremor. Action tremor divided into postural sustension tremor, which is observed in the limb and track, actively maintained in certain position, such as holding the arm outstretched. And kinetic tremor. When using the hand, we call the task-specific tremor. And intention tremor. Intention tremor characteristically a manifestation of limb cerebellar ataxia, hemispheric cerebellar ataxia. Practically, with action tremor, only exclude intention tremor, and the cause of postural and task-specific is the same. We will take in detail one of the diseases presented with postural tremor, which is essential tremor. Essential tremor primarily occur when a patient maintains a posture and may present during movement, particularly postural adjustment. Look at this photo and follow the arrow. If we ask the patient to put his arm, his upper limb in the resting position, we will not have a tremor. But in outstretched posture, the tremor will appear. This is large amplitude postural tremor, characteristically of essential tremor. May be associated with head tremor called titubation. Titubation in horizontal, we call it no tremor. Essential tremor most commonly affected the upper limb. However, head and trunk may involve, but you should remember, essential tremor characteristically not affected the lower limb. And for a large extent, involvement of the lower limb exclude this disease. Progression of essential tremor is typically slow, with intermittent, lengthy period of stable symptom. Alcohol consumption suppressed symptoms in most patients with this condition. This is very common problem. أنا أتذكر خريجين يمكن 2014 كان يعني من أصل هم فوق 100 يعني يعني 7 أو 8 عندهم essential tremor. Okay, the second type of involuntary movement is chorea. داء الرقص. Chorea, it means dancing in Latin. The word chorea denotes continuous, low amplitude, rapid, non-repetitive, non-rhythmic. So it's extremely not similar to tremor. Purposeless muscle jerk that unpredictably in timing, direction, and distribution in different parts of the body. The movement flits from one part of the body to another in random sequence. Chorea is there is range of the severity. Maybe we describe the full-blown picture, but in mild cases, maybe it's not more than restlessness. Maybe then become a jumpy movement of the hand. Then progress to be severe that the patient have continuous flow of movements of limbs and head and accompanies facial grimacing and tongue movement, which is full-blown picture. Milkmaid grasp is a good maneuver to elicit chorea in mild to moderate cases. In severe cases, everything is clear, no need for that. There may be difficulty in maintaining muscular contraction. This is a rule in chorea, such that, for example, hand grip is relaxed intermittently. So ask the patient to grasp your finger, and he intermittently relax and contract your fingers. Tone is decreased. Hypotonia, you always associated with chorea associated with hypotonia. Gait is dancing gait, lurching from one side to other side. Speech, it become irregular in volume and rhythm and may be explosive in character. Chorea characteristically disappear during sleep. There is many causes for chorea, and chorea can be inherited or acquired. Acquired causes of chorea include a wide spectrum of causes, from vascular to immune-related to trauma to metabolic causes, hematological causes like polycythemia rubra, and paraneoplastic, and sometimes associated with kernicterus. There is inherited causes of chorea. Treatment of chorea. When chorea is due to treatable medical disorders such as polycythemia rubra, thyrotoxicosis, adequate treatment of a primary disorder abolish the problem. Because when we said treatment of chorea, we mean the symptomatic treatment of chorea. An inherited a problem. So we need inherited problem, or there is no different therapy for underlying a problem. So we need symptomatic treatment. Chorea respond to drugs that interfere with dopaminergic inhibition of a striatal output neuron. There is a group which can achieve this biochemical change. Drugs that deplete dopamine from nerve terminal. We have reserpine and tetrabenazine, which is widely used nowadays in treatment of chorea. Dopamine D2 receptors blocking drug, such as neuroleptic, typical and atypical. It was used in the past, but nowadays tetrabenazine is used more than this group. Chorea generally responds to anti-epileptic drugs such as valproic acid and carbamazepine. Okay. The second third movement disorder. This is rare, but it's related to chorea in a way or another. So I put it after chorea. And differentiated from the chorea by, it is a very large amplitude choreic movement, often repetitive, violent, flinging and flailing movement. يعني رفس of the proximal part of one limb, monobalism or one side hemibalism. The lesion localized to contralateral subthalamic nucleus, and the most common cause is stroke. But really, I don't know why they linked balism to chorea. It is large amplitude. يعني ماكو مريض الطب إذا ما يضرب الباب لأنه رفس إيد أو رجل. And it is repetitive, and chorea characteristically not repetitive. So it's, although it is rare, it's highly characteristic. And it has special phenomenology. Dystonia is very important movement disorder. Dystonia is a severely disabling syndrome characterized by sustained contraction of agonist and antagonist muscle group in the same body part. leading to twisting and abnormal posture, with or without repetitive movement. Any movement, if I want to do flexion of the elbow, naturally there is inhibition of the extension of the elbow, because any movement has agonist and antagonist. If the contraction happened in the agonist and antagonist in the same time, so there is what we called it dystonia. Dystonia characterized by a twisting, التواء, and abnormal posture. يعني background, abnormal posture. Because the contraction of the agonist and antagonist may be not equal in the same time, we may recognize a repetitive movement. So there is something called dystonic tremor. Dystonic tremor is dystonia, but not a tremor. But we called it because it is repetitive as dystonic tremor. Dystonic movements are typically patterned. Patterned, it means involve the same group of muscle, and may be tremulous. Dystonia occur with lesion of the lentiform nucleus putamen and globus pallidus. Dystonia have a wide range of types and causes. So, approach to dystonia is by age at onset, because diseases and diseases that cause dystonia is completely different between childhood and adult age group. It is not only different in etiology, it's even different in phenomenology. And we will see how can that different. So the age is the starting point in evaluation of patients with dystonia. What is the body part affected by dystonia? And this body part affected is also related to the age group. We are focal if we have one part of the body, segmental, two or more contiguous body region that affected, multifocal, two non-contiguous or more, يعني ممكن يكون two or more body region, generalized, the trunk, and at least two other sites are involved. Body distribution, the treatment is different. Temporal pattern, the disease can be either static or progressive. The variability and this temporal pattern also affected by the age and the body, part of body affected. The variability can have 4 different patterns: persistent, action specific, diurnal fluctuations, and paroxysmal. And the treatment may be different in these groups. The last one is the associated feature. Is the dystonia is the only manifestation of the problem, or it is combined with other manifestation, what we call the dystonia plus syndrome. Isolated dystonia is dystonia that only motor feature, with the exception of a tremor, because we said there is something called something called dystonic tremor. Although dystonic tremor is dystonia, not a tremor. We called it dystonic tremor. The etiology could be inherited, could be acquired, and could be idiopathic. Idiopathic, either sporadic or familial. And there is different type of acquired. Can be infectious, which is a large group, drug-induced, metabolic, neoplastic, and it's very important that although the pathogenesis is completely different between Parkinson and dystonia, maybe the opposite, and it is a complication of a drug used in Parkinson, but sometime, strangely, surprisingly, that dystonia and Parkinson can be found in one patient, and maybe patient with Parkinson presented with dystonia. That's because the basal ganglia have two pathways, direct and indirect, and maybe there is affection of both in the same time and cause this diversity. Childhood dystonia, childhood onset dystonia typically begin in the leg and progress to become generalized and usually genetic origin. Conversely, on the opposite, adult onset dystonia are sporadic, not genetic, non-hereditary, commonly affected the craniocervical area and remain focal. So the age differentiation is very important because it's completely different. Nowadays, there is very important, since more than 15 years, there is something called, we highlighted this type of, actually, the first published paper more than 40 years, but highlighted in the last 15 years that there is something called dopa responsive dystonia. Any child purely with lower limb dystonia, the starting, as we said in childhood, starting with lower limb, with diurnal fluctuation in symptom severity, with a gradual worsening of symptoms throughout the day, the patient should have a trial of dystonia. At the start, we started the trial for 3 weeks. Nowadays, for 3 months. For any child presented with this typical pattern, but also with atypical, start the dopa, which may induce dystonia in adult age group. But in those patients, we have a trial because it may be this type, this strange type of, and the patient can live normally the rest of his life with dopa intake daily. The treatment of dystonia have oral medications, chemodenervation with intramuscular injection of botulinum toxin, and surgical treatment with deep brain stimulation. Now it's available and can be effective alone or in combination for dystonia. The oral medication of dystonia include anticholinergic, benzodiazepine use, clonazepam, tetrabenazine, the drug used in Korea, can be used in dystonia, presynaptic dopamine depleting agent, muscle relaxant like baclofen, but these muscle relaxant usually used add-on with other local injection of botulinum toxin and usually in focal and sometimes in segmental dystonia. Deep brain stimulation يعني بالضبط شو اسمه البيس ميكر اللي زرعوه للهارت هذا للبرين. زين. Use the treatment of dystonia. There is a type of movement disorder called ethytosis with slow distal writhing, wriggling, continuous jerky movement of the limb. Ethytosis is distinguished from dystonia by the lack of sustained posture. Actually هنا يعني the opposite لعلاقة الباليزم والكوريا. I think they called it high amplitude chorea, but it's unrelated to chorea. Ethytosis, always the authors try to differentiate it from dystonia, but I think it is linked to dystonia in a way or another. Ethytosis is distinguished by dystonia by lack of sustained posture. It is rare, so we no need for spend time with this type. Tic. I think you know what you mean by tic. اللي يعني traditionally الناس تسميها سولة. And tic in general it is a benign condition. But please remember there is what we called it malignant tic. So tic should be considered as a serious problem. Although commonly affected teenage male patient which pass benign, but it can be malignant. Tic are discrete, brief, repetitive, stereotype وحدة تشبه اللغة, non-rhythmic, semi-voluntary. Semi-voluntary is suppressible. That if you ask the patient to suppress this movement, he can't do that for a while. So it is suppressible and unwanted muscle contraction, which vary in quality and severity over time. Can affect virtually any muscle group. We call it motor tic or sound, phonic or vocal tic. And some say even the phonic and vocal tic, this is phonic and vocal, it's also a motor, but affected the muscle of the larynx. وين المشكلة هنا؟ دائما parents الأب والأم they recognize that it is suppressible. When they ask their son to suppress, he can do it for a while. So they think it is voluntary, not involuntary. ويجيني الطفل خطية شابع كتل. دكتور ايش قد اقول له ويقول له يرجع يسوي هي عاند. This is involuntary movement. This is a disease movement. This is even not physiological. هو الفيزيولوجيكال يسوي غصبا عليه. It's not physiological. Tic are preceded by an urge, sensory sensation, abnormal sensory sensation. This abnormal sensation relieved by doing the tic. Characteristically, the tic can be continuous during sleep. And many patients diagnosed as epilepsy, which is completely different from epilepsy, but because of continuous during sleep. So if it is continuous during sleep, why we consider it, or why the parent consider it as voluntary? He's in sleep. يعني آخر مريض أتذكر شفته تقول لي قلت له هي الأم تقول لي إنه it's continuous during sleep بس هي شابعتها كتل طبعا قلت لها لما هو during sleep شلون تتخيلين ان القضيه هو يسويها؟ هذا هو نايم وانت تقولين نايم. اوكي. Depending on muscle or muscle groups involved, tics are classified as simple or complex. When the initial sign is a motor tic, it's most commonly involved the face, taking the form of sniffing, blinking, forced eye closure. يظل بس يرمش ولو قوة يسد ويفتح بعينه. We will take this syndrome, which is a common disease. Tic is a manifestation. Angelus de la Torre syndrome is a syndrome characterized by chronic, lifelong, multiple motor and vocal tic of unknown cause. This syndrome symptoms begin before 18 years of age. The course is one of remission and relapse. تجي أوقات يصير زين أوقات يرجع. Most of cases are sporadic, although there is occasionally a family history. Male are affected more commonly than female. In general, tic affected male more than female. All patients eventually develop a number of different motor and vocal tic. Should be have more than one tic, so it's motor and vocal. The first sign consists of motor tic, and 80% is the presentation of vocal. Vocal tic in 20%. There may be either single or multiple tic. In general, it is generally not possible to make the diagnosis when the patient presented with the first tic, whether it is motor tic or vocal tic, because we can pass it as a common type of tic that presented during adolescence and disappear when the patient reach the age of 20. Those patients who have tic in age above 50, for example, they almost always have history of tics in the first 2 decades of life. يعني عادة من نسألهم اللي يتذكر، طبعا مو كلهم يذكرون انه they have a tic during first decade and disappear and regain later at the age of 50 or more. Physical examination usually reveals no other abnormality in patients with Angelus de la Torre syndrome. So it's diagnosed on a combination of more than one tic. Rarely, cervical tic may be so forceful and violent to be malignant Angelus de la Torre syndrome. The violent tic usually in cervical area and sudden abrupt contraction of the neck, inflection, and mostly in extension, caused whiplash, a fracture, and can lead to death. Treatment for patients with tic, by the way, can be associated with other diseases. But in general, this is not like Korea, that the treatment should be directed primarily to the cause, because treatment of tic, symptomatic treatment of the tic is required most of the time. Dopamine is the main problem in the balance of dopamine is the main problem in developing of tic. So dopamine depleting or blocking medication that blocking the receptors of dopamine are the mainstay for treatment of tic. The most important part in the treatment of the tic is education of the patient, and more important is the family member, and teacher is important. يعني والله ما اعرف in our circumstances يعني فوق ما الطفل هسه اوكي حتى لو كان بالتين ايج هي benign و suppressible and it will be disappear after age of 80 to 20, but it may lead to behavioral abnormality or psychiatric abnormality according to the response of the family and the teacher. يعني ما ادري مريض التك عندنا متهم ليش ما اعرف. The main agent for tic are antipsychotic. عندنا الفيرست جنريشن والسكند جنريشن هي used nowadays. عندنا presynaptic dopamine depleting agent tetrabinazine used in Korea and in Dystonia. Very wide tetrabinazine used in movement disorder. Side effect is يعني safety profile is very high. Okay, dopamine agonist. بس راح تقولوا لي ما هو انت صرت تعطي شو اسمه in tic pathogenesis is not completely understood. So sometimes we used dopamine agonist, not dopamine depleting. But for a small group of patients, a selected patient. Anti-epileptic, not like that of Korea and Dystonia. Topiramate is the drug of choice in patients with tic. Topiramate is widely used nowadays. Okay. We have a syndrome called restless leg syndrome, Ickbom syndrome. This is always, we put it in with the diseases of the cause movement disorder, but the patient didn't feel any movement disorder, only the relative, because the movement disorder of the motor part of this problem only happened during the sleep. We have sensory part, which is restless leg, and the patient should move to relieve this restless, and the motor part, which can happen during the sleep. It's divided into primary, with a noun cause, or with no apparent cause, and secondary. The treatment of this problem, which is common, usually if there is coexistence iron deficiency, anemia, correction of iron deficiency, it will abolish this restless. But the syndrome may respond to levodopa, dopamine agonist, clonazepam, gabapentin, and opiate. We have an enormous group of movement disorder. Maybe in the past was highly recognized, but nowadays, because of using of a new generation of antipsychotic, fortunately, decrease in incidence and relatively decrease in incidence. The most common important movement disorder is tardive dyskinesia. Tardive, it means late onset. Tardive dyskinesia is the clinical disorder characterized by choreiform movements. احنا طبعا يعني we have trouble with defining movement and in the face. Where movement is a change in position across a joint. In the face, there is no joint, but it's characterized by, this is the description, choreiform not chorea. It is not movement. Chorea form bucco, lingo, masticatory movement that are often especially prominent about the face and mouth in adult. Late tardiness mean late. It happened 6 months after starting antipsychotic. The problem is the pathogenesis of this movement disorder. It is not blocking of receptors or depleting of dopamine like those with other movement disorder. No, here is hypersensitivity of receptors to dopamine. So what we can do, if the drug that induces this hypersensitivity can cause depleting of dopamine. So the treatment suggested should be increase the dose. But when we increase the dose of the offending agent, naturally it will increase the movement, this movement disorder. So what we can do for until 4 to 5 years, there is no treatment. But nowadays we use tetrabenazine to treat this type of movement disorder. There are stereotype orofacial dyskinesia, including smiling, chewing, pouting, and grimacing, and tend to be more obvious in children, just like in dystonia, started in the limbs, and usually in the lower limbs. We have two types of movement disorder, part of drug induced, which is acute dystonia, and tardive, late dystonia. And we discussed dystonia in detail. Acute dystonia is rewarding to treatment, and it's commonly due to antiemetic drugs. Akathisia is a state of motor restlessness, but not like restless leg syndrome. That it is characterized by inability to sit or stand still, which relieved by moving about. There is a motor feature, not like restless leg syndrome. There is include frequent complex stereotype movement. يحرك بإيده يوديها stereotype. لكل مريض اكو special type. يمكن راح تقولوا لي الحركه ما هواي ناس تحرك رجليه هيك. Okay, fine. But if it's developed with patient take antipsychotic, we should raise the concern of this type of akathisia. And in the past, when the old generation antipsychotic, the most common cause of poor compliance to treatment was akathisia. This type of movement affected women more than female more than male. It may be early with the first doses of antipsychotic, and may be late, tardive. Happened after more than 6 months. We have a neuroleptic malignant syndrome. Maybe this is rare type of complication of antipsychotic drug. It's very important because the patient presented with drug intake and should be differentiated from encephalitis. يعني ذكر واني طالب بورد جابوا الابن رشد كنا نداوم شهرين سايكاتري patient with neuroleptic malignant syndrome, and in Ibn Rushd diagnosed as encephalitis, later on found to be يعني after time wasting found to be neuroleptic malignant syndrome. فسألت السينيور دكتور السيدة براد هات لي نيورو maybe missed this patient is your patient and you start antipsychotic and he developed this syndrome. Why we didn't raise the concern of neuroleptic malignancy rather than encephalitis? The patient presented with rigidity, poverty of movement, fever, altered mental status, and autonomic dysfunction. Yes, this is the all manifestation may be found in patients with encephalitis. But if the patient presented with this syndrome after intake of neuroleptic, we should have high index of suspicion of this rare syndrome. The last drug-induced movement disorder is Parkinsonism. Maybe it is differentiated Parkinsonism from the Parkinson disease, that very rare patients with drug-induced Parkinsonism have tremor. Usually patients with Parkinson disease have combination of poverty of movement and hyperkinetic movement. اثنين مريض واحد. Please look at this diagram. There is a balance in the neostriatum between the dopamine, which is inhibitory neurotransmitter, and acetylcholine, which is excitatory neurotransmitter. This balance is disturbed with drugs that block the receptors here. Look at the arrow. So there is dopamine and there is acetylcholine and it's balanced, but the patient cannot use the dopamine. So there is no decline in dopamine like in Parkinson. The patient develops poverty of movement and you need to stop offending problem. No need to give dopamine like in patient with Parkinson. No need to give any treatment. Only stop dopamine depleting agent and the patient will use it here and the balance will maintain and everything return back to normal. And thank you. إذا عندكم كومنت عيني عندكم سؤال.
دكتور بالنسبه للاكيوت ديستونيا الاوكيولوجايريك كرايسيس اللي تجي للطوارئ تعتبر اكيوت ديستونيا مو؟
طبعا acute dystonia. This is one example and common example of acute dystonia and it's rewarding for a treatment, although it is self-limited. If you stop the treatment, he will return back to normal within 72 hours. 48 to 72 hours, but it is painful. So we cannot stop. We cannot leave the patient for this period of time. So we should treat him.
زين دكتور انت ذكرت البنزاتروبين كدراج اوف تشويس.
اي.
زين البروسايكليدين ممكن همات؟
ممكن بس البروسايكليدين يعني ننطيه احنا عاده بس الافكت مالته ليت. يعني ان اكيوت ديستونيا.
زين دكتور بالطوارئ نوبات
بس جيفن طبعا انتي كولينرجيك ان جنرال طبعا جيفن.
دكتور بالطوارئ نشوفهم ينطون الارمين يعني هم ما ينطون
انتي بالضبط انتي هيستامين one of the choices, although the efficacy is low but one of the choices.
زين دكتور من ضمن هذين اللي اخذناهن عدا الاوكيولوجايريك كرايسيس شنو ممكن هم في ايمرجنسي يعني من ضمن الموفمنت ديس اوردر اللي اخذناهن ممكن تجي ايمرجنسي عدا الاوكيولوجايريك كرايسيس؟
عدا الاوكيولوجايريك كرايسيس يعني تقصد مثلا بالباركنسون مثلا تقصد شلون يعني تقصد يعني
هسه اخذنا احنا عده شو اسمه عده ديزيزز يعني هذن ممكن يجين بالامرجنسي قسم من عندهن عدا الاوكيولوجايريك كرايسيس. الاوكيولوجايريك يعني هي drug induced in dystonia one of the emergency.
akinesia can be emergency. I think the most urgent movement disorder هو neuroleptic malignant syndrome. The most urgent. He presented just like encephalitis. And we should differentiate this problem from encephalitis. I think this is the most important. يعني Korea, whatever the cause, is not emergency. Dystonia, okay, it is disturbing the patient, but it's not emergency. Except the drug induced, early مو تردف emergency. But the most urgent هو neuroleptic malignant syndrome.
زين دكتور، احنا كمثلا كروتيتر شنو واجبنا انه تجاه هذا النيورو مالجنانت